Welcome to May edition of the Urology Journal Club podcast. We're covering a 2026 editorial in European Urology titled Regional Node-Positive Bladder Cancer, Therapeutic Decisions Based on Trial Results in Perioperative and Advanced Disease Settings. Locally advanced bladder cancer includes tumors that have spread to regional lymph nodes, what clinicians call CN-positive disease. The key distinction here is between CN1, a single involved node, and CN2-3, multiple nodes. That distinction matters because, as this editorial explains, the two groups behave differently and likely need different treatment strategies. For patients with CN0 or CN1 disease and no distant metastases, the standard of care is now perioperative systemic therapy combined with radical cystectomy. Two landmark phase 3 trials changed practice here. In cisplatin-fit patients, adding perioperative durvalumab to gemcitabine cisplatin chemotherapy significantly outperformed chemotherapy alone. For cisplatin-unfit patients, the combination of enfortumab vedotin plus pembrolizumab delivered notably superior outcomes compared to cystectomy alone. Both trials did include a small number of CN1 patients, suggesting these individuals can benefit similarly to node-negative cases. The picture gets more complicated for CN2-3 disease. These patients represent a highly heterogeneous group, and critically there are no dedicated phase 3 trials for them. What we do know from retrospective data is that induction chemotherapy followed by radical cystectomy can achieve pathologic complete response in up to 19% of patients, and up to 60% may reach node-negative status after chemotherapy. Patients who achieved that node-negative status lived longer, which is encouraging. The 2-year overall survival in the Clipperley study was 63% for patients who went on to consolidative surgery. For CN2, 3 patients managed with systemic-only approaches. Data from the EV302 and CM901 trials show promising response rates around 50 to 63% complete response, particularly in patients with lymph node-only disease. However, neither trial was powered specifically for this subgroup, so conclusions remain cautious. The editorial's bottom line is clear. While perioperative therapy plus surgery is now standard for CN01 disease, CN2-3 patients need individualized decision-making. Novel first-line combinations, especially EV plus pembrolizumab or GC plus nivolumab, are preferred with selective, consolidative local therapy considered for appropriate responders. Next, we're covering a secondary endpoint analysis of the EMBARK trial, published in the Journal of Urology this month. EMBARK is a phase 3 randomized trial enrolling over 1,000 men with high-risk biochemically recurrent prostate cancer defined by a PSA doubling time of 9 months or less, and no evidence of distant metastases on conventional imaging. Patients were randomized to one of 3 arms: enzalutamide plus leuprolide, leuprolide alone, or enzalutamide monotherapy. This paper focuses on that monotherapy arm versus leuprolide alone. The headline finding: enzalutamide monotherapy significantly outperformed leuprolide across multiple secondary endpoints. At 5 years, patients on monotherapy had an 87% rate of remaining free from distant metastasis versus 82% for leuprolide, a 39% reduction in risk. Freedom from symptomatic progression was 67% versus 53%, and freedom from a first skeletal event was 96% versus 92%. Overall survival trended in favor of enzalutamide, 89.5% versus 87.2%, but did not reach statistical significance, and the data were immature. One important trade-off: after treatment suspension, enzalutamide patients resumed hormonal therapy sooner, about 10 months versus 17, likely because testosterone recovers quickly without castration level suppression. Sexual health, however, was significantly better preserved with monotherapy. The bottom line: for men with high-risk biochemical recurrence, enzalutamide monotherapy is now a regulatory approved, clinically meaningful option, and these secondary data further support its place in shared decision-making conversations. Next, we consider immune checkpoint inhibitors for high-risk NMIBC. This editorial critically appraises two landmark phase 3 trials, CREST-sasanlimab and Potomac durvalumab, evaluating PD-1, PD-L1 inhibitors added to BCG induction and maintenance for BCG-naive high-risk NMIBC. Both trials showed an identical 32% relative risk reduction in events HR 0.68, translating to modest absolute benefits of 7.3% and 4.4% respectively at 36 months, with no improvement in progression to muscle-invasive disease. The authors contextualize these gains against significant toxicity. Grade 3-4 adverse events occurred in 21-29% of patients, with discontinuation rates more than double that of BCG alone. The NNT to NNH ratios 14:4 for sasanlimab, 23:6 for durvalumab highlight an unfavorable risk-benefit profile. The authors conclude that 2-year BCG maintenance alone remains a reasonable standard, and that shared decision-making is essential before these agents enter routine clinical practice. Next, we look at the PERI-PRO trial, targeted and perilesional prostate biopsy. The PERI-PRO trial is a non-inferiority randomized controlled study that evaluates whether a combined targeted and perilesional biopsy, TPLBX, can effectively replace the traditional targeted and systematic biopsy, CTSBX, for patients with MRI visible lesions. Analyzing 380 biopsy-naive patients, the study found that TPLBX was non-inferior to CTSBX in detecting grey group good game dollar, GE dollar, 2 cancer, 58.4% versus 57.9%, and good game dollar, GE dollar 3 cancer, 30% versus 29.5%. Crucially, the TPLBX approach utilized fewer biopsy cores, which led to significantly lower complication rates, specifically regarding rectal bleeding, hematuria, and rectal pain. Additionally, TPLBX demonstrated practical advantages by shortening procedure times and reducing pathological examination costs. The researchers conclude that TPLBX is a safe and efficient alternative for diagnosing clinically significant prostate cancer while minimizing the morbidity associated with extensive systematic sampling. Lastly, we consider the European study of prostate cancer screening 23-year follow-up. This short expert commentaries responds to the 23-year ERSPC follow-up data. The first commentary highlights that PSA-based screening reduced cumulative prostate cancer mortality by 0.22%, risk ratio 0.87, preventing one prostate cancer death per 456 men invited, while other cause mortality was identical between groups, countering the argument that screening merely shifts cause of death. The authors argue that the inability to detect an all-cause mortality benefit is a statistical limitation inherent to all cancer screening trials, not evidence of inefficacy. That's all for May. Look forward to seeing you next month.